again. Does the history fit? Are there any red flags? You know, a lot of us think about when we deal with these functional disorders, and I think we're going to hear more about that today, functional gastrointestinal disorders. We look for red flags as pediatric gastroenterologists, and that's how we tell if there's something to do. And of course, is the baby at risk? Remember the risk of the damaged baby. So other things to think about: metabolic, central nervous system diseases, careful developmental assay, developmental examination to see if the baby's falling behind. Is there anything going on in the environment that might be messing this thing up? You know, figure all of that out. Then consider if you need to do any kind of dietary restrictions. If the baby has colic, that's when we go into explaining why babies cry. And reassure the parents, but this is where you have to be very positive. This is what your baby has. This is what we're going to do about it. No equivocation. Don't give them the sense that you don't know what's going on, because that will increase their anxiety. We've looked for these other things. You know, there's nothing to suggest that there's anything else going on. Explaining the swaddling, the soothing, the repetitive stimulation. You know, one mother said she wore out 3 vacuum cleaners before her baby quit crying, because the only thing that would make it better was to turn the vacuum cleaner on. You know, so, and little things like that. I put in here some, if I have time, I'll just talk about other potential things that you can do. And then the final thing is make certain that the parents take you seriously, and that you give them the impression that you really care about it. Because one of the, and this is true with all functional gastrointestinal disorders, is if you give the parents the impression that this isn't a big deal, go away, you know, there's nothing wrong with your kid, that's not what they want to hear. The kid has a problem, they brought a problem to you, they want you to fix it. It's a real thing, and you have to treat it like a real thing and really help it. So if there's any other things that you can do, what are they? Well, probiotics. This is Lactobacillus reuteri DSM 17938. Now, I put this in here because if you're going to use a probiotic, you have to make sure that you got the right strain. And hopefully, when Professor Kanani talks about tolerance and allergy, he's going to talk to you about Lactobacillus GG, which is a very specific strain of probiotic that's been shown to work in milk protein allergy. And if you don't have exactly the right strain, it won't work, because all the strains are different. So here's one very specific strain of Lactobacillus reuteri, which seemed to work in breastfed babies. However, another study done that looked at a combination of breastfed and formula-fed babies with colic, and it didn't work. So what's the truth? I don't know, but I know there are some people that try this in breastfed babies, but you know, you got, like you say, you got to make sure you got the right strain if you're going to use a probiotic. Oral hypertonic glucose. There's a few papers that show that giving small quantities of oral glucose solution will make the baby's colic better. The problem with this, of course, is, you know, you can't do it instead of feeding the baby, because obviously he's going to lose weight. So it's just, yeah, I mean, it's just something that occasionally, so well, you can do this occasionally if it gets really bad, and maybe it will help. Complementary medicine is always, everybody always wants to look at things like probiotics, herbal tea, different kinds of supplements and whatever. And there's very little indication that any of these may work. I think there was one study with a certain herbal tea that showed some benefit, but not very good studies and not very much data. And even chiropractic. There were a few studies that showed that chiropractic worked in babies with colic, but the only one of the studies that was actually done in any kind of a decently controlled fashion showed no benefit. So I think probably doesn't work, but it has a placebo effect. So there really isn't much here to use. So I think you're kind of back to the same place where we were before. Is this a colicky baby? Is it an allergic baby? How do I tell the difference? What do I do? And then let's try to get that parental anxiety under control and get that mom settled down so she doesn't make the baby crazy and the baby doesn't make her crazy, because that's actually what's going on here. Make sure they understand that the baby's not sick. Point to the normal growth and development. See how your baby's growing normally. This is fine. Your baby's going to be just fine. He's just expressing himself. You know, you need to not overreact to this thing so much. Talk about that curve, that cry curve, and how it goes and how it ends up and how things are going to get better. Talk about how crying can be reduced by changes in how the infant is handled. I mean, I can't tell you how many times I see these mothers holding this baby out and screaming and yelling. And he says, "Give me the baby." And you're kind of, the baby's fine, you know. Give the baby back to the mother. So, I mean, you could show them that and kind of help them understand how that works. You know, what was yesterday's? I thought another great comment. Don't pick the baby up every time it wiggles and screams a little bit. You know, let it cry a little bit first. Let it learn to soothe itself, and that a lot of times will help. These moms are, because of their anxieties, they're overreacting to this thing. They're just making themselves crazy about it. So anyway, I guess we have. I do have an airplane. Questions after this thing. So I won't answer any questions, and I hope you found this interesting. I'm happy to give this talk here because I'm in Indonesia. Nobody's going to refer me another fussy baby here, so I won't give this talk in the U.S. Thanks, Jeff.
I'd like to thank John. I think this has just been, I think you've been exposed to a masterclass from a senior clinician. And it's wonderful to see how years of experience can be just put into place for what is a common problem, but with a very simple solution in many respects. And so you've just witnessed a masterclass of clinical medicine in that regard. It also reminds me, I've heard too, that when you're talking about the baby when they're first born, there's a growing sort of population or trend on the internet talking about the fourth trimester.
Yeah.
We were actually born too soon. And in fact, you could probably blame DHA and things when in the Rift Valley when the brains got too big, the babies wouldn't come out through the pelvis. Well, they should be here for another 3 months. If you think of all these issues, they actually occur in those first 3 months of life mainly. And if we were born at 3 months of age, in fact, many of the problems wouldn't have happened. So we're born too soon. And it's never going to change, because I don't think the ladies would really like to go sort of 15 months of pregnancy, would you? But that's also... And the other thing, just a comment too, is that you talked about the protein sort of preservation. I always think too, I think of it in terms of the reason why there's a relative lactose malabsorption in the infancy is because it's feeding the microbiome in the gut and helping the microbiome to develop. So this is another, nature doesn't make a mistake. So anyway, John, I'd like to thank you and give you the obligatory Botox photo.
Oh, wonderful. Yeah, I use Botox, but not on the face. But
I'd now like to introduce the second speaker of this morning, that's Professor Neil Shah. I introduced Neil yesterday in his titles with respect to Great Ormond Street and his myriad of research experiences, but he's here today speaking because of I think probably his first love, and that is in the allergy space, where Neil has been absolutely seminal in helping to sort of craft the guidelines that are around the world, and I'm sure Neil would talk to you about that. One of his guidelines is the most downloaded guideline ever. I think that's right, Neil, isn't it? The IMAP sort of guidelines which are in clinical use. So I've asked Neil to talk about the true diagnosis of cow milk allergy, because as you'll hear, it is not as straightforward as one sees, and there's a lot of complexity in this process. Again, we'll be experiencing a masterclass from a very experienced clinician. So, Neil.
Is this on? Oh, great. Right. Okay, so I'm sure every woman, only a man would turn around and say, the women can have another 6 months, sort of. The Y chromosome just doesn't think sometimes, does it? So I have various titles, some grand, and this is my role at RB, but I'm going to be talking to you as a clinician, not as an academic, but someone who sees this, and once a week I see a lot of children that cry, but for a different reason. So this is where my hospital